all over India, and Kerala is also going to be included in the pneumococcal vaccine trial. I think we're going to have the 13 vaccine in Kerala too, but the other option is also now available, and that's what we're going to discuss today. The vaccines that are now available in the market today are PCV13, PCV10, the two, that is Synflorix, and the new PCV10, that is
Listen, please unmute.
yeah. So we need to now discuss why you need a new vaccine at all. Because now we had PCV13, we had PCV10, and PCV13 is what we're going to include in the National Immunization Schedule, UIP. So why should we have another vaccine? So that is why we are discussing today. And I understand that all of you would be already using these vaccines. The 13 valent vaccine had 3, 4, and 18C, which were in excess of what is there in the PCV10, the new PCV10. The Synflorix, which was available earlier, as we know, didn't have 19A and 6A, and that was reason why it was not able to take care of the cross-reactivity to 6B and 6A, and 19A was causing a lot of disease, which caused with a lot of antibiotic-resistant organisms. So that is the reason why PCV13 became popular. Both PCV13 and the new PCV10 Pneumosil have CRM17 as the conjugate protein, while PCV10 had the protein D of the type, that is H influenzae, and type of H influenzae as the conjugate protein for each of the serotypes. 18C had tetanus toxoid as its protein, and 19F was conjugated with diphtheria toxoid. So we had 3 different proteins to cater to the serotypes in PCV10, while both PCV13 and PCV10 had only 1 each. So the advantage that PCV10 was saying that they had the untypable H influenza and therefore take care of the otitis media, which is caused by H influenza, which was not really very significantly more severe, more effective than the PCV13. So now we're going to discuss why did we remove 3, 4, and 18C from the PCV13 in the new vaccine PCV10. The WHO recommends that PCV10 and PCV13 are both effective, and the studies in various large-scale studies, nasopharyngeal carriage and vaccine type IPD, the impacts were almost similar, not very different between PCV10, the old Synflorix, and PCV13. But in areas where 19A or 6C was significant, in countries where it was very significantly high IPD caused by these two serotypes, maybe PCV13 was more effective. And the choice of the product would be depending on the local regional prevalence of serotypes, vaccine serotypes that cause the disease. So in countries where you had more of 19A, 6A, and 6C, maybe 13 was better. That was what was decided. But generally, both of them for effectiveness, it was almost okay. Now, the problem with serotype 3, we all know the antibody response to serotype 3 is poor. So in India, it is very low prevalence also, less than 1% by ASIP basis and Josna's review article. It found that the incidence of serotype 3 in India was less than 1%. And most countries like Denmark, France, Greece, Portugal, Sweden, UK, US, they showed that the effect of serotype 3 to PCV13 was poor. And therefore, the WHO and SAGE, the evidence suggested that in the current PCVs had a consistently substantially did not have a substantial effect on serotype 3. The impact was poor. And the reason was because of the very, very huge capsule that these serotype 3 had. This is the normal capsule of a normal PCV, serotype Pneumococcal 19F, for instance. And this is what the capsule of the serotype 3 is like. So it's abundantly capsulated, making bacteria less sensitive to immune interactions. It also causes severe disease because of this. It behaves differently from other serotypes, therefore. So the 0.35 microgram per ml, that is the antibody response that the targeted antibody response, response that you expect from the vaccine, that says that this correlative protection is achieved. That amount of antibody is not able to have an effect on the serotype 3 because of this huge capsule that it has. And so new approaches are required. And there are studies which show that you need to have other proteins like conserved pneumococcal proteins on your vaccine to overcome this problem with the huge capsule that the serotype 3 has. And these conserved pneumococcal proteins that have been identified are PSPA and pneumolysin protein antigens. Now, these produce cross CC180, three distinct clades. Clades, that means three distinct antigens are produced, which will be very antigenic first thing. Secondly, it will express high level in vivo, the antibodies, and it is able to give good protective immunity. So these, when there is these conserved pneumococcal antiproteins in the vaccine, probably it will be more effective against serotype 3. So that is not there in either PCV13, PCV, or the new PCV10. So therefore, the new PCV15 that is coming up probably has it, because they say that it is going to be a slightly better effect against serotype 3. So till then, PCV, there's no point having extra serotype. The less serotypes you have in a vaccine, the better the antibody response. The more effective if more serotypes are there, because cross-reactivity is very poor. So you need to have serotypes for a particular IPD to prevent a particular IPD. But the less the serotypes, the more the effect. So therefore, you can reduce the amount. The PCV10 is reducing one serotype that reduces serotype 3 because response is very poor anyway. The other two, serotype 4 and serotype 18C, these are the other two that were removed from PCV13. This is the reason why, because there is absolutely no serotype 4 or 18C in India. 0 and 1%. That is what was shown in 0 for serotype 4 and 18C1. All over Asia, Africa, Latin America, everywhere, the incidence of the serotypes 4 and 18C are not very high. India is very, very low. So therefore, it is prudent that we remove these these serotypes and from PCV13 and include 19A and 6A, which are there which causes disease, and you have a good vaccine which would cover as much of serotypes that produce IPD as PCV13. and you're having less antigens. So that is the reason why there's less serotypes in your vaccine. So that is what PCV10, the new PCV10 is all about. 6A, as you know, there is you need to have the 13 PCV13. The 6A is there in PCV13, and therefore definitely produces much higher response than PCV10, because PCV10 doesn't have 6A, and there is no cross reactivity, cross reaction between the 6B that is there in PCV10 and 6A. So 6A is something that requires to be there in the vaccine. So the PCV13 definitely is better than that for 6A. 19A, there is some response to 6A, but the antibody that's produced is not very avid and not very strong. And as we have already mentioned, the cross reactivity is much less. The antibodies produced by cross reactivity is much less than with a particular with the type specific serotype. So therefore, direct protection rendered by serotype included in the vaccine formulation is significantly or definitely superior to any cross protection offered by unrelated serotypes, even in the same group in any PCV formulation. So therefore, the 6B that is there in PCV10 would not give a cross protection to 6A. Therefore, you have 6A, 19A, 19B is there in PCV10, but that's Synflorix, but it doesn't cover the 19A. So therefore, 19A, 6A is included. What is removed is 3, which is not anyway doesn't produce very good response, and 4 and 18C, which the response, the prevalence in India is very poor. So you have removed 3 from PCV10, and you've added 2 from PC into the vaccine that is 6A and 19A. So that is how you get a wholesome product in PCV10, the new PCV10 Pneumosil. You have 1, 5, 6A, 6B, 7F, 9B, 14, 19A, and 19F, and 23F. So this will give you a good protection against most of the IPD that is produced in India. And the conjugate protein, as we always said, is CRM70, 197. It is also got WHO pre-qualification, and the shelf life is about 36 months at 220 degrees centigrade. But the new studies have shown that it may be slightly more, maybe up to 48 months. So that means the shelf life is good, very low aluminum content, and you have the ideal serotype combination in as far as India is concerned. And it is a CRM 197 carrier protein with all the serotypes have 2 micrograms except for 6P, which is 4 micrograms. So this is your presentation of your PCV, the new PCV10 Pneumosil. And when you do a comparison of the IPD serotypes that are prevalent by the Alliance for Surveillance of Invasive Pneumococcal, that is ASIP, the basis study and a 10-year review, all of them have shown that almost 75%, 73 to 75% of the serotypes are covered by both PCV13 and the new PCV10, that is Pneumosil, while it is slightly less with the Synflorix, as you expect, because 19A and 6A are not covered. So this is the pattern that gives you a feeling that this vaccine might work. Now, the clinical trials, have been 5 good clinical trials already, and there are a lot more happening. The 5 RCTs have been done so far, and in India and in Africa, and it's been done in adults, toddlers, and infants. One is phase 1 trial in India was a comparison with Pneumovax. It's for safety. Then we had this phase 1 and phase 2 Gambia study with comparison where with Pneumovax, that is the polysaccharide vaccine, and the Prevnar 13. That was for safety and immunogenicity. That contained 112 toddlers and about 200 infants, 6 to 8 weeks. So this is the that was a good study. Then you had a phase 2 trial in India with PCV. The comparison was with Prevnar 13. That was used all the PCV naive toddlers, 12 to 15 months of age. The Gambia study, the 3 doses were given at 6 and 14 weeks. And there was no booster in that subset. While the phase 2 study, with comparison with the Prevnar, they used the 8 weeks apart, they gave it those children who had not had any PCV. Probably they would have had a pneumococcal disease early. I don't know. We don't have information on that. But 12 to 15-month-old babies, infants were taken and given 2 doses at 8 weeks apart. 108 toddlers were included, and safety and immunogenicity was checked. Then we had the phase 3 Gambia study with comparison with Synflorix, which we'll go into detail. There we had a 3+1 schedule, where 6 and 14 weeks and 9 months was the booster given. And the booster data from a subset of 30% of infants. So you had 2,250 infants were put into the study, 6 to 8 weeks inclusive at day 0. And you had a safety and immunogenicity non-inferiority study. The phase 3 India study had a 3+0. That means there's no booster. That is again with Prevnar and Synflorix. So only the Synflorix study in Gambia had 3+ booster, while the phase 3 India trial had that is comparison with both Synflorix and Prevnar had 3+0 in their study. And the reason why they included 3+0 alone without the booster was that most of the disease occurs in the first year of life in India, and therefore 3 boosters would give you ample protection. So that is the reason why the booster was not included in this particular study. Safety and immunogenicity was checked in that. Then you had the phase 3 2+1 study, where you had the 2 doses given in infancy and a booster. 6-14 weeks, you had the initial doses, 6 and 14 weeks, and that is 8 weeks apart. And then you had a booster at 9 months. And here again, Synflorix and Prevnar were the comparators, with 336 infants were included. That's an ongoing study, which is almost complete. The phase 3 Gambia study also is 2+1. So all these combinations have been tried. Gambia is included because it's a developing country, and therefore probably studies from there could be extrapolated to India. And therefore that's the significance of that studies were maybe relevant for Indian conditions too. So this is the reason why so you had these studies on 3+0, 2+1, 3+1, 2+1. So a lot of studies have happened so far, and there's going to be post-licensure impact studies also as that will be proposed. That's a proposed study which will happen as the drug is being given now to a lot of children in India. Now we're going to start with the Gambia study, the phase 3. We said 3+1 schedule with comparison with Synflorix and Pneumosil. And as I already mentioned, this 2,250 children were included in this study. Now, the 3+1, I said 14 weeks, and a 9-month booster was given. Now, this is the percentage of response. And as you see, 6A and 19A was poor with Synflorix, as expected, because it doesn't have 6A and 19A. The rest were almost similar, except 23F, which was a little low with the Synflorix. So the Pneumosil was found to be non-inferior to Synflorix to all serotypes by percentage responders, except for the 6A and 19A. And this is the 0.35 micrograms per ml IgG post-primary IgG levels, again, which showed that 19A and 6A did not respond with Pneumosil. So Pneumosil elicited superior immune responses to Synflorix for serotypes 6A and 19A, as I mentioned. both percentage-wise and GMC criteria. So therefore, those two, the study showed that it was effective in comparison with Synflorix. The OPA titers, which gives you a better indication of the response to vaccines, also was assessed, and an OPA titer of a percentage of more than 1:8 is considered as significant. And here again, the response was very good, except for all the serotypes that are there in the vaccine, except with Synflorix, you didn't have 6A and 19A as expected, was very poor. So the OPA titers also showed that the response to primary vaccines, the 3 doses of 6, 10, 14 weeks was good. Primary titers, again, the same thing, it showed the same. Post-booster OPA titers also showed that very good boosting at for 6A and 19A with the Pneumosil, and you had almost nil response to the boost effect with the Synflorix. So therefore, the effect post-booster GMTs were high with Pneumosil in 9 of 10 serotypes, and significantly higher in 7 or 10 serotypes. So therefore, it was significantly better with the Pneumosil compared to Synflorix. The post-booster opiates GMTs, that is the IgG titers, no serotype was significantly higher for Synflorix for booster OPA response. And therefore, the response was very good with the Pneumosil compared to. So the trial summary showed that lot equivalence was confirmed, and overall non-inferiority of the immune response to the Pneumosil compared to the Synflorix was confirmed for all 10 serotypes, and Pneumosil did not interfere with EPI vaccines. So it was given along with the DPT and other vaccines, and it didn't interfere. So these were the response of that trial summary. And the boost effect was there for all 10 in both treatment groups, and significant booster response in for OPA and GMT titers. Post-booster IgG GMCs was higher with the Pneumosil compared to Synflorix, and post-booster OPA titers were again high with Pneumosil in 9 out of 10 serotypes, and significantly high in 7 or 10 serotypes. So this safety was also very good, and I will not go into that for lack of time. So Pneumosil, therefore, after this Gambia study, got the WHO pre-qualification letter. The phase 3 trial then by then had been started in India, and this had Pneumosil with comparison with both Synflorix and Prevenar. A total number of subjects were 448, and they, as I already mentioned, the PCV naive children were selected. 6 to 8 weeks were given, inclusive of day 0, and the 3-dose vaccination was started at 6, 10, and 14 weeks of age, and Prevenar 13 and Synflorix were given. So this was PCV naive children who had the vaccine at 6, 10, 14 weeks without the booster, 3 plus 0. This was the schedule that we mentioned. And here again, the titers were excellent for all 3. So for OPA responders, 4 weeks post 3 doses, for all 3, the responses, as you can see, you got a robust OPA response from all 10 of Pneumosil, favorable comparison to Synflorix and Prevenar. And here again, you found that the 19A and 6A also, you had good response to Synflorix, the first 3 doses, but the dose ability may not be very good, because the this is the GMTs again. The GMTs also showed that the the response to 6A and 19A was not very great with Synflorix. So in conclusion, Pneumosil was highly immunogenic and induced robust serotype IgG and OPA responses to all 10 serotypes. The study data indicates comparable immunogenicity of Pneumosil with Prevnar and Synflorix for all 10 in OPA. Robust OPA results are clinically significant in the light of increased clinical response. The Pneumosil is safe and well tolerated in the 3+0 schedule. ACVIP, therefore, in 2020-21 recommends that Pneumosil can be given till 2 years of age, a 3+1 schedule with booster administered at between 12 and 18 months. Though at that point we had only a 3+0 study, the Gambia study showed that there was response. Therefore, ACVIP recommended that the booster could be given within 12 and 18 months of age. Thank you. This is the post-licensure study in India.
Thank you, sir. Over now.
Yeah.
Thank you, sir.
Thank you.
There is no questions in the chat. I invite questions. Any queries, please?
Are you all using the Pneumosil or using Prevnar?
Possibility of non-vaccine serotype pneumococcal vaccine if we use these pneumococcal vaccines for prolonged periods. Possibilities of natural selection for emergence of non-vaccine serotype pneumococcal infection.
Now the serotype
emergence of no-vaccine serotype pneumococcal infections.
Yeah, the serotype replacement is something
that is serotype replacement, and that is what I am asking.
Was studied in a big way when PCV7 was initially used, and we found all the studies have shown that the serotype replacement doesn't produce enough disease IPD to overcome the effect of the vaccine effectiveness. So it might produce a little bit of disease, but it does not. It's not enough to say that the serotype replacement is going to do any harm. That's why it has not been talked about nowadays, because initially it was a big issue. You're only using 7 serotypes, and you have so many other serotypes. That's when 19A came up, 19A, 6A. So when those two vaccines came up, then that was added. After that, there's not been much of severe disease caused by other serotype replacement serotypes causing severe IPD. 19A was causing a lot of disease, drug-resistant pneumococcal IPD. 6A also was causing a lot of disease. So that's why those were serotypes which are replaced. These are not there in PCV7. That's why it is included in PCV13. Since then, we haven't had much of serotype replacement disease.
Okay, thank you, sir.
Dr. Ron Dagan, who is the expert in pneumococcal vaccines, says that when you give this vaccine, it not only changes the milieu of the oropharynx, and other viruses and bacteria that are present in the normal milieu of the oropharynx also are affected by these pneumococcal vaccine, and they are sort of suppressed. By giving pneumococcal vaccine, you might prevent other bacteria that are there in the oropharynx from causing disease. That's his theory. So he says the vaccine changes the whole oropharynx, the bacterial milieu, and the disease pattern will reduce with extensive coverage with pneumococcal disease. You get less of respiratory problems due to bacteria and viruses. So he brought that up when in Indonesia we had a talk, we had a session, And he was very strong on that. I haven't seen any more studies on that, but there's been no refutal to that concept.
Any special schedule for these planetomized or other immunocompromised patients?
Immunocompromised patients, you can only give the conjugate vaccine if they're not their CD4 titers are not very low, CD4, and if they're very immunocompromised, then you shouldn't be giving vaccines. But otherwise, the conjugate, all the skill vaccines can be given. So if you give a pneumococcal vaccine, the conjugate vaccine, then you have to give your PCV, the 23, that is the second vaccine 1 year after your pneumococcal vaccine, the conjugate vaccine 1 year after, and maybe you can repeat that after 5 years. That is something that depends on the new immune status of the person as he grows.
In special reference to splenectomized patients?
Like those patients, they should get their pneumococcal vaccine before the splenectomy is done, at least 4 weeks, 2 weeks before. But the word splenectomy would all polysaccharide containing bacteria, all these opsonification causing bacteria like meningococcus and pneumococcus need to be covered. The only thing is that both these vaccines should not be given together if you're using Menactra and PCV13. That is only contraindication. Don't mix Menactra with PCV13 because it causes a lot more fever and blood seizures. But Menbio, which is available now in India, can be combined with PCV with the conjugate pneumococcal vaccine. And the pneumococcal vaccine should be given if you're giving Menactra, then you give pneumococcal vaccine first and Menactra 1 month later, and then do your splenectomy 2 weeks after that. But if you're using Menbio, you can give both together before 2 weeks before the vaccines. Which similarly for your cochlear implant. But you should ensure. Suppose you're unfortunately given a polysaccharide vaccine, then you should not give your PCV for at least 8 months to 1 year after your PCV. You're given your pneumococcal vaccine. I mean the polysaccharide vaccine.
Any more questions?
In how many states it is being given in the national immunization program so far?
So far 5, but I think it's going to come all over India now. Kerala is also included in that list, but so far 5, and we don't know the response there. How many people have been given the vaccine? How many children have got the vaccine properly? They were giving 6, 14, and weeks, and then at 9 months, 3 doses. But how many took the 3 doses? How many? We don't have data on that. Data. I don't have it, at least. That was a WHO estimate which showed that those 5 states had the maximum number of pneumococcal deaths, IPD deaths due to pneumococcus. That is why those 5 are selected. How many of you all are using pneumococcal vaccine? Yoshi,
We are using.
I am using.
You're using for all your patients.
Yes.
How you use that? What is the compliance when you say you take the pneumococcal vaccine? See, there's a scare that you say pneumococcal vaccine, people run away.
No, we have to educate them.
Yeah.
We have to spend some time.
Yeah.
Even my relatives, they were IT fellows. They were first reluctant. They came
Some
from-
children are given vaccine from the government sector, and the same day they come to our hospital for pneumococcal vaccine.
Yeah. See, even next day, 2 days later, can you give the pneumococcal vaccine after you gave your DPT and all that?
We are giving it on the same day.
Why should you? Can you give it on 2 days later or 1 week later?
But the vaccine cost of the Prevnar is very huge, around 4,000.
No, that's why this Pneumosil is much less
Yes,
costlier.
that's good.
It comes around 2,000 rupees.
Yeah, it comes around 2,000. But see, you can give it any time because all the
That
vaccines.
1 month gap is not required.
Not for killed vaccines. Not for killed vaccines. Killed vaccines you can give any time. See, if you give MMR, only for viral vaccines you have to give it together. Suppose you give MMR, can you give pneumococcal vaccine the next day or 2 days later? Can you? Parmeshwaran?
Yes, we can.
We are not giving like that.
We can
Why?
give.
You can.
We can
Believe
give.
me, because the kill vaccines and the viral vaccines act in different mode. The viral vaccines, they infect a lot of cells all over the body, and it's a huge response. Cytokine response is immense. So another virus vaccine which is the same method will not act, will not be effective. So you need to give a gap of 1 month. But kill vaccine acts locally in the local lymph node. Therefore, it doesn't interfere with the viral response. Viral vaccine response doesn't interfere with the kill vaccine response. So you can give. So if you give MR today, you can give 2 days later, 3 days, you can give any kill vaccine. So there are a lot of people who give. When a child comes after an MMR and you require a DPT, you don't give. So no, you can't give because of this concept that you need a gap of 1 month. It's not required. The two different modes of action for these two types of viral and kill vaccine. Therefore, you need not give this gap of 1 month except for viral vaccines. Viral vaccines have to be given together in the same day. So, hepatitis A, if you're using the BioVac A, MMR and varicella. These you have to give together on the same day. But oral vaccine, live vaccines doesn't matter. Doesn't have any. It's a local, more of a local action. That whole cytokine response all over the body doesn't happen with OPV and with rotavirus and also. There's no problem.
Is it a question?
Shall we stop?
I think if there are no more questions, we can stop.
Don't not give the vaccine. Some vaccines don't not give the vaccine because if they're coming for a viral vaccine immediately after another viral vaccine, they will give vaccine. Okay, thank you.
Okay, Juman. I invite Dr. Juman for vote of thanks.
Thank you, Dr. Akbar Sadiq, Dr. Jeeson Unni, senior members and dear friends. It is definitely a very important topic in the present scenario. As we know, it is a major cause of neonatal and infant and child death. And also, as we know, in Kerala, government is going to implement pneumococcal vaccination in universal immunization program, in the routine immunization schedule. And definitely this talk was very interesting and very extensively discussed. Almost all the aspects of various aspects of the pneumococcal vaccine are discussed by Jeeson C Unni, sir. Thank you, sir. We are expressing our sincere gratitude on behalf of IAP Malappuram. Thank you, sir. And also, I am expressing our sincere gratitude to all the members, all the pediatricians and general practitioners who attended this program. Thank you all. Also, we express our gratitude to the Serum Institute of India. Thank you all. Thank you very much.
Thank you, Dr. Joshi. Thank you, Dr. Parmeshwaran, Akbar, and Juman. And of course, Venu.
Thank you.
Thank you, sir. Thank you.
Thank you. Good night. Good night.
Good night. Good night.
Good night.
Good night.